course there are. But again, in the practical world, we have to go, what can we actually do that we're not already doing? Right? How many of you are already doing strength work with people? Mobility work, hands-on work?
Yeah.
Cool. If you're already doing all that, and you are not succeeding in what you want to achieve, then we have to go, what other tissues can we actually try to activate or alter in some way? So that's really what led to kind of these particular points of focus, as well as just looking at, like I said, the substrates of everything that becomes interoception. So, what are things you remember about interoception from this morning? Very simple. Just give me some, what do you remember?
Integrated system.
Integrated system. What does that mean?
It integrates.
All right, very simply. Will visual input change interoception?
Yes.
Will vestibular input change interoception?
Yes.
Okay. It is actually impossible to divorce interoception from other activities. Because remember, what is the primary job of interoception? Prediction of what? What do you say? Right, it's actually homeostatic prediction. So basically, anything that I do that requires you to do anything other than what you're currently doing requires the interoceptive system to prepare, right? And that's really, really important for us to understand. How many of you, again, thinking about it from a non-physical perspective, how many of you know that if you have some very significant mental effort coming up, you have to prepare for it? Right? This weekend, right? They have Sell My House. I know that if I'm going to be doing a lot of writing, for instance, let's say I'm prepping a new course or have a conference coming up I'm speaking at or whatever. At this point, I've been in this business long enough and I know my own process enough that if I walk into my office and it's a mess, for whatever reason, I know that I will not get the work done because I have like informational ADHD, right? Oh, look, a book on neuroscience. Oh, wow, interesting. Right? Like I'm supposed to be presenting on sports and I'm reading on the amygdala and I'm like, okay, how can I make the amygdala about sports, right? So I have to prepare my space. So I know that I have some things that I need to do. So, like I said, everything is about preparation for what's coming on the interoceptive level. All right, so we know it's predictive. We know that it is specifically predictive toward maintaining homeostatic activities on an autonomic level. What else do you remember about interoception from the morning? What are some classic signs of altered or dysfunctional interoception? What is it associated with? What did you say? Depression and anxiety. The thing that most people will immediately associate it with are what we consider often mental disorders. Hopefully, at some point, we will finally get rid of that designation completely. We just have dysfunction. Right? Your knee can hurt, your heart can hurt. It's all brain. Right? So like I said, at some point I hope that we get rid of these dividing lines between what's considered a mental, emotional, cognitive illness versus physical. It's all one system. But that is typically what you will hear. What else? What do you say? Obesity. Okay? So definitely eating disorders and obesity. And again, we can think about a lot of eating behaviors probably as a form of self-medication. Not because I love the sugar or I love the whatever, but simply because the stimulus being provided by chewing, by swallowing, by breathing, by expanding the stomach, those are all forms of vagal stimulus. Does that make sense to everybody? Okay? So, unfortunately, we don't, depending on where people are, maybe they don't want to, they need the stimulus of chewing, but they don't like to chew gum because they don't want to be rude. So now they're nibbling every 20 minutes, 20 minutes, 20 minutes, 20 minutes, not because they're hungry, but because they need stimulus. Okay? What else? Other dysfunctions associated with interoception?
Disturbance in anything that is served.
Right. Anything served by the vagus nerve. Oops. Right? Can be tons of things, right? So if you start at the top, we said the vagus nerve is going to lead through the jugular foramen, attached to or sharing what? Sharing space with cranial nerve 11. We then have a superior and inferior ganglion coming out of that. The superior, we're going to get what? Meningeal afferents or meningeal fibers. As we move to the nodose ganglion and then down into the throat, we're going to start to get both laryngeal and pharyngeal innervations that is sensory to the brain and motor from the brain. So a lot of your voice tone, your ability to swallow, your ability to articulate, use the tongue, vagus driven. As we move past the throat, we then go to the cardiac and pulmonary branches. So anything to do with the heart, anything to do with respiration, those are vagal. We then go to the esophageal portion. Below the esophageal, we have the gastric portion. So we have, again, control of the esophagus, but also all the tubes passing through the diaphragm. And then when we go subdiaphragmatic, we're then getting vagal innervation of the gut. So we have now the stomach, we have the pancreas, we have the spleen, we have the intestines, we have the liver. That makes sense to everybody, right? So all of those different things are going to be contributing into maybe altered or dysfunctional interoception. In T phase, we start palpating people's abdomens. And in T phase, we typically talk about it from the viscerally mediated pain perspective, right? I've got this chronic weird right shoulder pain. It's non-specific. It's kind of in this general area. I can't reproduce it with movement. It aches all the time. What are we going to do? Sometimes we'll go in and palpate around the liver, gallbladder, and they're like, oh, wow, it doesn't hurt anymore. All right, so again, this is just another layer of thinking about that. All right, what else do you remember about interoception? Yeah?
Overly emotional responsibility.
What do you say?
Overly emotional responsibility.
Often a overly emotional response to anything. Okay, and particularly a excessive emotional response to what? What you feel, regardless of what that is. Okay, it can be pain. I can have chronic pain. I can be hypersensitive. But again, just maybe a inability at some level to control emotional responses to things. Remember that the insular cortex and interoception give things emotional content. They are the affective part of what we're experiencing. So we talked about this idea, and probably the biggest thing I wanted you to remember on this from the morning is that it is possible to become too aware. In becoming too aware, you can become inaccurate. And when you become inaccurate, you now maybe start to actually have some increased threat responses. Does that make sense to everybody? There was a study from 2017 that looked at all these different measurements of interoception, interoceptive accuracy, interoceptive awareness, and then what they call basically subjective body awareness. And what they found were the people with the highest levels of subjective body awareness actually had the lowest levels of comfort. In other words, their subjective level of well-being went down, down, down the more self-aware they became of their body. Okay? And that's not about accuracy, it's just this general feeling of I'm always noticing everything about my body, right? And you've probably had these clients before that can tell you, right, you know, they can feel like their hair growing. I literally have had people tell me that. Does that sound weird? Like, just, you have no idea how many I've heard, but I literally had a couple people over 20 years ago, yeah, I can feel everything. I can even feel my hair growing, and I'm like, no, you can't. But whatever. So, like I said, we have to be careful in practices. The reason I'm bringing this up, like I said, is in the fitness world, we see now an inclusion of lots and lots of practices from around the world, right? Particularly in our society. We see a lot of yoga, we see a lot of Tai Chi, so we see basically a lot of Eastern systems coming in. Interestingly enough, what's happened, and this is just a social commentary, we've taken a lot of original Eastern systems and we've tried to make them more gentle and more kind than they were ever originally designed to be. We Americanized it. We said you can learn it quickly, right? This is not a 10-year practice. This is you can learn in 12 weeks, right? Just learn your process. And then we made it really gentle. Again, because people do experience, some people who are relatively healthy get good benefits from it. But if you go the wrong direction with that, you can actually see people get worse. So you really, again, have to think about all of this not from the tool perspective. There is no perfect system. It's just application. And great teachers, great instructors, great coaches, whatever you want to call it, are just simply really excellent at modifying the tool to make sure that it works for the person standing in front of them. I have told people for many, many years I have become more and more agnostic about all forms of exercise, all forms of therapy in every system I've ever seen, because it is not the system. Every system can help you and every system can break you in the right hands. So we just have to, again, be really, really careful of always promoting one thing or the other. Yeah.
So if someone doesn't have interoceptive awareness, you can do some of that training like we did this morning.
Fantastic.
But if they're overly sensitive, how do you help because I have some clients that are like that. They're like, I can feel food moving through my, like
Mhm.
moving down my esophagus, being like through
Yeah.
each part of their digestive system, and I'm just like, I don't think.
Cool. That's not, yeah, that's probably a little too much.
Yeah.
So what we're going to be doing throughout this weekend is talking about, and just as we would in all other forms of neurology, activations and inhibitions. So we'll do a little bit of stuff on inhibition, because that's also super important. All right, so is everyone good?
Yeah.
All right, before, oh, sorry. I saw this. Pardon me? Yes, there is a left and a right insula. We're not going to talk about it too much. We are going to talk about side-to-side, like targeting of input. The reason that we're not going to spend a tremendous amount of time on rights and lefts right now is we don't have enough information, but what is starting to show up is there is a definitive gender difference in right and left activations based on what you're doing.
Awesome.
Which makes it really, really complicated. They actually there was a study just a couple months ago looking at insular activation from isometric exercise. And what they found was actually a very significant gender difference between what portion of the insula was activated regardless of the side of body being exercised. Wow. So now, like I said, that's kind of next step stuff where it gets more complicated and a little bit more irritating, honestly. It'd be way simpler to just go, yeah, just always work the right side for the left side, which is what we're going to do here. With the caveat that you may have to actually dig in more deeply if they're really messed up. But like I said, right now there are differences between right and left, what they process. The biggest differences, though, that we're seeing are probably gender specific. Most likely that has to do with a lot of different elements, but we think probably more exposure to long-term exposure to estrogens continually show up changes in genders or in brain function between the genders. And again, you guys have heard me say this before. The really sad part is neuroscience in women is about 7 years old. Sorry. So I didn't do it. But yeah, it's weird. It is, yeah, I guess probably 7 or 8 years ago was the first time we actually started seeing female-only neuro studies. Now they're finally starting to do some comparative studies, but you know, research was always based around the 25-year-old or 22-year-old college male, which is a great representative species. Everyone's just like a 22-year-old male. So it's coming, so hopefully we'll know more in a couple of years. Yeah.
I think I just heard a story on NPR where they weren't even doing gender differentiation on on long-term studies that use blood samples or tissue
Correct.
samples.
Yeah.
So.
Yeah, science is growing up, guys. That is what it is. We actually, for the longest portion of human history, it was believed that you're just a human. Right? We know there's differences. You can have a baby, I can't, whatever. But you need me to make a baby. Right? That was about it when it came to science, right? Everything else should be the same. So stuff has started to shift, but it takes a really long time to create these kind of tidal shifts in just the research protocols. So it's coming. Yes, sir.
Yeah, just one more. Do we know or how the strength has to be for electrical stim to reach the vagus nerve, and what ranges they do the?
Yeah, so that is coming. He's asking about how strong electrical stimulus needs to be to affect the vagus nerve. So what I did for this class, I actually built a few new slides for you guys, and I will go through it with you. Because what's interesting is all this kind of new electrical stimulation concepts began with the vagus. But as soon as they began seeing success with the vagus nerve, they were like, well, can we go after other nerves? So right now, in the neuromodulation world, they do transcutaneous vagus stem, transcutaneous trigeminal, transcutaneous facial, and they're actually now starting to connect that with also just like old school dermatomal TENS unit stimulation through the spine and cervical, throughout the spine. Depending on the pathway, they have differential effects. So when you start stimulating like the facial nerve, trigeminal nerve, it goes more into the spinal trigeminal nucleus. If you start to look at the different routes, you basically can say, hey, vagus will probably impact amygdala function, nucleus tractus solitarius function. If I go after the face, I'll go after maybe the ACC a little bit more. So they're actually now starting to use neuromodulation therapies for different reasons. So I put together a little bit of that for you, and basically right now we have some ideas about how much, how intense, etc., but it's still a lot of guesswork, so I'll just show you what's currently in the literature.
And for the vibration plate, did you play around with, for example, having the deep muscle stim, where you can change the RPMs and just be on the stomach area or different organs instead of the whole body?
I have done that. Actually, it's a good question. I haven't thought about that, but maybe if you remind me on Sunday, I'll kind of give you a comparative background. So he's talking about using vibration plate versus like targeted E-stim on the abdomen, just to get different like localized vibration. So we can talk about that. You ready to do some work?
Yeah.
Okay. Remember, insular cortex, vagus nerve. What's number 3? Unmyelinated C fibers, right? Free nerve endings. Does everyone remember they are everywhere?
Yeah.
Okay, 80% of all afferent nerves are, 90%, sorry, of all the 80% that are afferent nerves are C fibers. So basically, anything we're doing in the body, we're going to create a huge amount of C fiber activation, particularly if we add some stress to it. So we're going to move into, like I said, our ACM work. I want to give you a little bit of background just in terms of why we're going to do this. So number one, before lunch, we talked about utilizing specific contractile exercises to influence brain function. Yes? Right? We talked about the PMRF pattern and the cerebellar pattern. Does everyone remember that?
Yes, sir.
Okay. So again, very, very important to recognize that sometimes people will maintain brainstem deficits because they are lacking appropriate peripheral activation. Is everyone okay with that conceptually? Okay? Yes or no? All right, so that's going to be very, very important for us. And we'll talk about, again, kind of how I've laid out the pathways and patterns for you to make sure you know which side to start on, etc. Before we go into that and start practicing, I want to also talk a little bit about the use of ACMs in a day-to-day setting. The vast majority of you will use them for strengthening work and also to change gait and like base level neuro function. How many of you are currently using isometrics as a pain relief tool? And how are you finding it?
Excellent.
Okay, it is actually, like I said, in the research world, it's actually a really, really growing in popularity tool because it works very well. Now, let's think about this. If I have a client coming in, right shoulder, right elbow, so let's say they have a right PMRF. Everyone understand that? If I give isometric exercises on the contralateral side of the body, make sense? If I give left isometric exercises, what's the pathway? Like, how's that all going to work? So it's going to be right cortical drive to create the left side isometric. Does that make sense to everyone? So that right cortical drive should also create ipsilateral PMRF activation, which may decrease my right side pain. Does everyone understand that pathway? Okay, so on the neuro side, we have that as one option. Could I also have someone come in with just right shoulder pain? They do not have a PMRF presentation in history. Could local isometrics around the currently painful joint also potentially decrease pain?
Yes.
Why? What's that?
It could be a
Lateral
lot of
inhibition?
receptor activation in that area, creating additional nociception. So getting ACM, that full muscle contraction could really do it.
Okay.
Or
So
stabilization.
we could give them stabilization. Remember, a lot of what comes down to these like local pains with no big overwhelming neuro problem is just motor control. They actually suck at a flexor extensor synergy. We figure out the right contractile pattern, they do it, and their brain goes, cool, the joint is where it needs to be now, I don't have to worry about moving it. Everyone understand that? Okay, and if you don't, I will try and go through this in more detail, but like I said, I want you to understand that you can do localized isometrics. If localized isometrics help, it usually is because they have a cerebellar problem on that side. That cerebellar issue means that they probably do not control the joint well, and more importantly, the joint is not actually sitting precisely in its capsule as it should be. If I have a cerebellar problem that's primarily showing up in my right shoulder what will happen at the glenohumeral joint? Where will it be positioned? It will internally rotate and probably also slide anteriorly slightly, because I now lack extensor tone. I have loss of extensor tone in my triceps, loss of extensor tone in my lats, loss of extensor tone posterior deltoid. So I can just now have some dysrhythmic activity happening in this joint, so every time I move it, I'm getting a threat response. So sometimes it's really simple, right? We have motor control locally. If I do contralateral, it's probably more through the brainstem. Now, having said all that, let's go a tiny bit deeper, because this is an advanced course, and we're talking about stuff on the inside of the body. So I may get pain relief specifically just through these physical processes that we've been discussing and how it impacts the brain. But we also all know that whenever we create changes in the human body, we're not just changing electrical signals. We're changing stuff at the neurotransmitter level. We're also changing stuff at the hormonal level. So just a couple of interesting findings. Is everyone familiar with our endorphin system?
Yes, sir.
Yes or no?
Yes.
What does endorphin mean? It is a combination of two words. Endogenous, morphine, endorphin. Basically, our inner ability to create opiates, right? Endogenous opiates. So we actually have our own pain control system where we can manufacture really high levels, actually, of opiates if we do certain things. What is one major driver for endorphin production in human beings? Pain and what? Exercise. Okay. So pain and exercise. We know that exercise done appropriately can increase endorphin production. Now, this is what most people associate with what? The runner's high. Right? Now, here's some cool research. All right. This is stuff that in 2016 they actually did some tests, and they were actually testing strength training to see how it would impact on localized pain. And what they found is they gave someone in pain, had them do some isometrics, their pain would go down. So the question was, does local resistive exercise, particularly isometric exercise, does that decrease pain through the endorphin system? So in a lab, you can do cool stuff. You can actually give someone a blocker, so you actually take the opiate system out of it. So the assumption was that if the pain relief is coming through endorphins, if I block that system, then you should not get any pain relief. Does everyone understand that? Yes. Well, they tried it, and they still got pain relief. So they went, okay, so obviously exercise induces pain relief through the endorphin system and through another system. Does anyone know what the other system is? What's that?
Endocannabinoid?
Yes. Okay, the endocannabinoid system. Your inner weed system. Some of you just were like, yes! I knew it! So the endocannabinoid system, if you're not familiar with it, actually incredibly complex, highly involved in multiple things regarding anti-inflammation, and also pain control, pain relief. You have multiple receptors. Now here's what we didn't know. Endocannabinoids were identified in the central nervous system years and years and years and years ago. That's why we know that cannabis actually makes people feel weird, right? You can get high from it, etc. So we knew that it had neurologic activity within the brain, peripheral nerves. What we now know is that basically all tissues, virtually all tissues, carry endocannabinoid receptors. In 2016, they took fascia from orthopedic surgeons, or from orthopedic surgeries. People voluntarily gave up some fascia during orthopedic surgeries. They did scans on all of them, and so we actually now know that all your fascia contains endocannabinoid receptors, along with all these C fibers. So one of the concepts right now is that localized muscle contraction, if you want to think about it that way, because of its impact on the fascial system, the fascial bag that contains the muscle fibers, you're not only getting C fiber activation, you're probably also creating some additional level of endocannabinoid receptor activity, which can also decrease pain. That's just a little factoid. I find it super interesting. So again, the whole idea for me is whenever we start doing these different ACM drills, I want you to think of them as a neural signal, right, specifically to change motor control, change PMRF function. But I'm saying all this because I want you to recognize the drills we're about to do are fantastic pain relief drills. Now, all of that is said to preface it this way. Whenever we start doing these kind of ACM drills, which are specifically isometric exercises, the current research on what promotes the highest amount of endocannabinoid activity, there is just a couple studies on this, but what it shows is that exercise of medium intensity works way better than exercise of either low or excessively high intensity. If I exercise too hard or with too little intensity, neither one of them turn on the endocannabinoid system. So if you're specifically using isometric exercises for pain relief, what does that tell us? The Goldilocks principle. Probably don't want to be going to 10 out of 10 tensions all the time. You probably need to keep it in that 6 to 7 intensity range. So that is just, again, one of the whole reason I went through all that was to get to that one point. Yeah.
And training that emphasizes the eccentric component.
What's that?
Training that emphasizes the eccentric components, I think that impacts the systems least as well. So you're most likely to suffer most discomfort from that style of training.
Correct. Yeah, eccentric, there's multiple reasons why you can suffer the most from that one, but that's one of the major reasons it does the least. Okay? So does everyone understand all that? Okay, so here's what we're going to do. We're actually going to start off working through some of our ACMs. As we do this, I want to make sure that we're really clear on the process. So let me actually get us over to past a lot of neurology that we can come back to. Here's going to be our basic protocol, all right? In your manuals that you guys have, electronically, you also have an extensive video library that comes with this course. That took a very long time to film. Poor Shannon. I don't know, it took us like 6 days to film all those videos. But the whole idea is whenever you're going to be doing contractile work, it really is important to know where to put your fingers. Right? So the first thing that you do if you're going to do ACM work with people is you need to look at a picture of the muscle so that you can visualize where you need to palpate. All right? And I will actually, as we go through each of the muscles, I'll be putting the pictures up here for you so that we can follow along. Once you actually know what muscle you're going to be doing contractions on, you want to visualize moving from a full stretch to a full contraction. And I know this seems a little bit, I don't know, protocol, but I've done this for many, many years, and I still, to this point, every time I palpate, I'm like, okay, what's the stretch going to look like? What's the contraction going to look like? Before I have to move. All right, it's just an easy way to make sure you know what you're doing. Before you begin doing any of the contractile work, I like to have you prime the pump, right? So a little bit of sensory priming. For our first iterations here today, as we start doing this, we're just going to do light skin stim. As we progress through the weekend, I don't care how you choose to prime the muscle, but you need to prime it somehow. So with your individual groups, you may find that some people need a Z-vibe, so some vibration, light skin, nociception, sticking, heat, cold. You've all done enough neurology with me at this point to know that I just want to find the stimulus that's going to give us the greatest amount of contraction. Everyone okay with that? All right, so we look at a picture of the muscle, we visualize the full stretch to the full contraction, we prime the area, and then when we're ready to actually start working on the contractions, what we're going to start off doing is going to palpate both ends. You have them start off hopefully in a full stretch position, okay? So full stretch to a full contraction. So we always, whenever possible, start them in the full stretch position. Our fingers are palpating into the muscle. We then are going to take them into that fully contracted position. Now, if you notice on number 6 here, it says start off with 2 to 3 moderate contractions. I'm going to give you some caveats to that based off the body part that we're working on. Because if you have a brand new person come in and really start to crank on some of these ACMs, it's going to not go well because it's just too intense. So you have to, again, grade the amount of intensity that you want them to do based off how much you've worked with them. All right? So after we've gone through a couple of our contractions, we then start to increase the intensity a little bit. Now, the biggest idea behind the ACMs is we are trying to use physical stimulus to make sure we're creating maximal activation. All right? If you're not familiar with how muscles contract, right? So if we think about my bicep, we have multiple small nerve bundles that are innervating different what are called motor units. Does that make sense to everybody? A motor unit is the nerve and then as it's the muscle fascicles that it innervates. So everyone do this. Take your left arm and start contracting your left bicep. Okay, start off at about 60%, contract 60%, 60. Now go to 70, 70, 80. At 80, you should be shaking. You're not shaking, you're not pressing hard enough. 90, harder, 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 harder. Now try to go to maximal contraction, hard as you possibly can. You should be shaking like crazy, and relax, okay? Now, why are the faces you're like, oh my God. Just a bicep, just contraction, you're fine. Now, most of us, whenever we're at that 100% and our face is turning red, we feel like we are generating as much tension as we possibly can, but you're not at all, okay? Because basically what happens is the muscle fascicle groups will basically fire in a relatively random order. We would like to think that muscles kind of fire very articulately and in a very coordinated way, but if we were actually had EMG on you, multiple pads, we can actually see, okay, you're contracting harder here, and then as you start to fatigue, whoop, the tension shifts over here, and then you start to fatigue, it shifts up here, and then it shifts down here, and it shifts over here. So what that means is that most people, when they feel like they're giving maximal effort, are leaving a lot of muscle fibers untended, underactivated. So whenever we're doing this and we're palpating along a working muscle, what we're trying to do is identify habitual areas of underuse within that muscle belly. Does everyone understand that? Usually what that will show is at my maximal contraction, there'll be somewhere within that muscle tissue that when I palpate it, it doesn't feel like everything else. It's going to feel soft or more relaxed. And then I'm going to use, again, sensory stimulus to go, no, 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 contract right here. So that's what the finger palpation is for. Does everyone follow that? Cool? Okay. That's the basic ACM idea. Now, as we move forward, we're going to talk about safety, because this is post-lunch. We're not going to start with the spine. I normally start with the spine. We're not going to start with the spine. We're going to actually start with PMRF muscles, so we'll do wrist and other stuff first. But I want to make sure that I cover this. All right. Whenever we start getting to the spine, I will remind you of this, but whenever we're doing things here, you need to know about their vascular health. You all know that in our phase, we don't teach cervical extension with rotation. Now, do I believe that you should be able to do cervical extension and rotation?
Yes.
Why do we not teach it at our phase?
Because we don't trust them.
Because I don't trust you yet, right? And there is a small possibility of someone suffering a stroke with extension, with rotation. So in general, if you have clients that have had neck surgeries, they've had their carotids roto-rooted, and all those other things, you're not going to do any of the ACMs that require cervical extension combined with rotation. Is everyone clear on that? Now, have I done it? Yes. Have I ever had a problem? No. But again, just in the general safety of the world, I would recommend if they've had a bunch of neck work done, you avoid that. All right? Secondly, if they are on Coumadin, warfarin, or any other blood thinner, I also avoid any kind of significant tension applied to the cervical spine for similar reasons. Whenever we start getting into more complex muscles, like we did with the lat, does anyone remember the lat sequence? What do we have to do with the lat? Internally rotate, shoulder extension, shoulder adduction, shoulder scapular depression. What else do we have to do? Anterior tilt, lateral tilt, side bend, rotate toward, all that stuff's supposed to be happening at the same time. Now, you guys can do that. Your average client that's just coming in for the first time can't, right? You might be good to get them to here, here, and here, and that's fine. Then we can just start to add some tension in those positions. So for your very complex sequences, maybe 2 to maybe 4 movements at most, and then you can add in more as you start to progress them. The other thing, obviously, keep tension levels low in the beginning because, again, people are new to this. They can cramp very easily, particularly when you're talking about the spine and some of the axillary muscles. They don't like that. They think that you've hurt them. particularly like the spinal ones, because usually the cramps will be in the intercostal muscles. And the intercostals, if they cramp on you, it feels like you've gotten stabbed, and like they can be pretty intense. So like I said, you just be intelligent, you start off, get people gradually working up into all these things. Does that make sense to everyone? Yeah.
If you did have someone who really thought that they went too far, I mean, can you reassure them that it's just a muscle contraction?
Yeah.
I mean,
You can reassure them and just go, let's go through the opposite, stretch it out.
but you haven't had, like, you can't hurt yourself, like.
Well, you can always hurt yourself. So let me give you an example, all right? Real world, horrible experience. I only had a couple. An undiagnosed osteoporosis person, 35 years old. Had her do a pretty significant side bend ACM, and she broke a rib.
Oh, boy.
35 years old, looked healthy, looked fine. Now, the important part was, although it was a horrible